Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Advances in Removing Invasive Pituitary Tumors, is presented by Dr. Paul Gardner. Please hold as there will be a brief delay while we change presenters.
Thank you very much for the invitation once more to be speaking to the PNA. It's always a pleasure to speak to this very important group, helping to both provide this community for pituitary tumor patients, but also to help provide education on advances within pituitary tumor. And, it's really a pleasure and honor to be associated with the association for so long. I chose to talk today on advances in invasive pituitary tumors because a lot of times these are really where the challenge becomes. Not all pituitary tumors are the same. They can be nice and small, or they can extend to some tricky areas to get to. And that's really what we mean by invasive. Traditional surgery for pituitary tumors is done with a what's called a microscopic transsphenoidal approach. Sphenoidal meaning going through the sphenoid sinus. But this has some limitations. There's a microscope that's used outside the nose, and there are certain areas that you can't see. And suprasellar means the tumors that go above the area where the pituitary normally sits. And there's an area called the cavernous sinus that we'll talk about, where the carotid artery and the nerves that move the eye are, that really are not well visualized, and therefore it traditionally has been contraindicated to access tumor there. And the reason is simply this. Here's a view of a portico on a bay, and I can have a microscope that sits outside, and I have a nice three-dimensional view. I have binocular eyepieces. I can zoom in and get a very magnified view, but no matter what I do, the microscope has to be outside this surgical field. An endoscope has an advantage because it can be placed actually inside this surgical field to allow me to see and then potentially do things safely that I couldn't do with a microscope. And here is a view actually of exactly the sphenoid sinus, and this is in a cadaver, and I have to warn ahead that there are a lot of surgical videos mixed into this talk, and so certainly want to make sure that warning is given. But here's a view in a cadaver of what you get, a view of the sella, and through that exact same exposure through the nostril with an endoscope, you can simply see a lot more and see it a lot better. And that has allowed us to really expand our approaches, to widen our access, to open up the sinuses more, to be able to get to pituitary tumors in a better way and be able to remove areas that we wouldn't normally be able to get. And this, over the years, has led to something called the endoscopic endonasal approach. And this is an approach that's done completely with an endoscope. The entire surgery, no microscope is used. It's done entirely through the nostrils. On both sides are usually used. And it's a series of different modules of approach to the entire area of the skull base, including the pituitary area and beyond. And this is developed in part at the University of Pittsburgh, and I feel very fortunate to have been part of that development. And here we've performed now close to 5,000 endoscopic endonasal surgeries, many of which are pituitary tumors. And I really want to make this point that pituitary tumor surgery is skull-based surgery. You might say, what is the skull base? Where the base of the skull is that part of the skull where the brain rests on. It's the area above your ears, it's the area above the base of the back of your head, and it's the area above your nose and right behind your eyes. So we think about it maybe as the back of our head, but it really extends the whole length. And here's a cartoon showing how we can access almost all of the skull base working through just the nostrils. And this is how we do it. We work with an endoscope at the 12 o'clock position in the right nostril, and this is working with two surgeons working side by side, and a suction in one nostril and maybe a dissecting instrument in the other. And we've also created these protective sleeves for the nose that we use, and you might see those in some of the videos here. Doing the surgery, it is my belief, is best done with a combination of two surgeons, and that's a little bit unusual. Not every surgery is done by a team of surgeons, but there really are huge advantages to that. If you got into an airplane and you were taking off and you realized there was only a pilot and not a co-pilot, you'd probably be a little nervous, even though probably it might go okay. But the same is true in surgery, and especially when we're working through the nose and the sinuses, it's important to have two different specialties who are skilled working together as a team. As a neurosurgeon, I want to see the pituitary gland well. I want to expose these critical landmarks like the carotid artery and maybe the optic nerve, and I want to make sure I have good working space for both hands, and also make sure that the endoscope really isn't too much of a in the way. At the same time, my ear, nose, and throat partner, the otolaryngologist, is trying to make sure that we preserve all of the critical nasal anatomy as well as the function, and they also play a key role in looking at things like reconstruction. How do we patch the hole that's left behind by the tumor? Now, the endoscopic approach has some very big advantages, partly because of this team, but partly just our ability to access areas that we couldn't access before with other approaches. And this is when we start looking at what's called extracellular or extension beyond the cella, and that's really where invasive tumors go. So the cella is the little area in the middle of the head where the pituitary tumor normally sits, and if we go back to this drawing, you'll see this drawing of the cella here. And so the cella here is this area right in the center. Let me see if I can pick up a pointer here or not. All right, well, we'll move on here. I don't see a good way to grab a pointer. But the cell is the central area where the pituitary sits. And when we talk about extracellular, we're talking about tumors that extend beyond that area. And so this is in areas like the cavernous sinus, which is the one that often people are understandably most afraid of, or extending up supracellular, which means up in towards the brain, or actually clival down towards digging into the base of the skull, which can be equally challenging because of other arteries and nerves in that area. And then finally, what we call subarachnoid, which means actually up into the brain substance itself. Now, the cavernous sinus, this is an area, and this is a picture actually, an anatomy picture of the cavernous sinus. And basically what this is showing is that there are a lot of nerves involved here. All the nerves for movement of your eye, as well as feeling of the face and muscles for chewing. And so you can see trying to get into that area. This picture is taken from an open surgery approach like we would do a craniotomy, such as an open incision behind the hairline, for example, or even in the eyebrow or other things like that. But an open perspective, really, this looks like a porcupine with all these critical structures facing up at us that we have to try to work through. Now, when we look at this endonasally, I really think of this like the belly of the porcupine. Yes, the carotid artery is still there, but all of the nerves are outside where we're working, and pituitary tumors start on the inside. They start in the cell of the pituitary, is the really very central area here, and that's where the tumors start, and they only extend out to this. So we're following a very natural pathway, and I think that's why this is sort of like the belly of the porcupine. So a really nice way to get at this area called the cavernous sinus, and so we can access through the cell and through the sinuses to get there. Here we can see a tumor in the pituitary. Try one more time here. I don't know if our if the webinar folks are able to help me find a pointer here, or a way to grab a pointer to be able to show some things here on the pictures. Okay, I guess not. Well, so this is showing a pituitary tumor here that's extending off into that cavernous sinus region. When we visualize it, we can see it, but the traditional opening or the traditional bone that's removed is what you see here. When we want to extend to this area called the cavernous sinus, we simply have to remove the bone. We just have to be careful and comfortable removing the bone over the carotid artery in this way. And here's an intraoperative video of exactly that tumor, with the tumor extending into the area of the cavernous sinus. Here we're thinning the bone and removing it over the pituitary, and then extending it out to the side. And then when we do this, you can see how we can very carefully thin and peel the bone away from the carotid artery. And by exposing the artery in this way, this allows us to then move the artery during surgery and safely work around it. This has been done thousands and thousands of times. It's a perfectly safe maneuver to do. Here we're using a special Doppler, which is using ultrasound to really confirm the pulse in the artery. So now we can open actually into the sella, the air of the sella that's been expanded or blown out by this tumor. And we start to see a typical pituitary tumor. And another nice advantage of the endoscope that really has been shown is our ability to really see the pituitary gland and preserve it. So here we're using a special hook knife, actually something we helped develop that helps us open into that cavernous sinus area safely. And then dissect between the carotid artery, because it's been exposed. We can safely work next to it because we can see it. We're not hiding it and trying to work around it. And then on the other side, separate it from the pituitary gland. And you can see here, there's a subtle difference in the appearance and this yellowishness of the pituitary gland. And what we're removing is this grayish sort of bloody tumor that we peel out. And we like to take it out sometimes all together in one chunk, but sometimes we can't if it's really invasive like this one. And so here now we're peeling away the medial cavernous wall. We're stimulating nerves to make sure we're nowhere close to them. And this allows us to do a safe removal of the tumor, even on the backside of the carotid artery. Because we've exposed the artery, we can use the endoscope to enter into that area and safely work there. And here you can see a complete removal of that tumor. It's very rare for us to get any deficits. If you look at this particular patient, you'll notice his eye is black and blue. And you might wonder why that is. That's not a result of actually anything we do with the surgery itself with our instruments. It's actually from monitoring the nerves for eye movement. So we can place little leads into the tiny muscles that move the eye. We can do this very safely. And that allows us to stimulate with electrical signal. These nerves are like wires. And we can monitor to make sure when we see the nerves that we don't damage them. So this kind of monitoring, while it can very rarely give a little bit of a black and blue eye, maybe about 5% or less of the time, it helps us preserve these nerves, and we've done good studies that prove that. Now, the more we realized that we could get into the cavernous sinus, the more we wanted to study this. And so the next step was to look into a cadaver lab and do some study that way in the anatomy lab and really look at what is the cavernous sinus, and discovered that there are ligaments that are connecting the cavernous sinus wall. And by understanding these ligaments, we could understand better how to remove them and how to safely remove the medial cavernous wall. And so here's a typical case of a woman who had very clear Cushing's disease, very bad Cushing's disease. You can see the arrow pointing at the tumor. She underwent surgery at another hospital by a very skilled pituitary surgeon, but he didn't chase the invasive area that goes into the cavernous sinus. And you can see there's a hint of tumor left, and her Cushing's disease never completely resolved. She never went through the postoperative crash that we look for, where those cortisol levels go super low and people start to feel withdrawal. So over time, symptoms got worse and there was more growth of the tumor there in that area of the cavernous wall. So here's a view through the sinus. This has been previously operated, so much of it is exposed. We're just removing a little bit of the fat graft there at first. And now drilling and again removing the bone over the carotid artery to be able to have access to this area. So this is not a big tumor, but a small tumor like this, of course, in Cushing's disease can have devastating effects. The critical piece here is that we've exposed this carotid artery. So now we open the dura, which is the lining of the brain over the lining of the pituitary, and we start looking for the tumor. We see a little bit of soft tumor there, but otherwise, we see this area in the cavernous sinus. There's a little bit of soft tumor. Otherwise, we see this area in the cavernous sinus involved. So I'm opening the cavernous sinus again with the special hook blade that we developed. And then this bleeding is very typical. People are afraid of the cavernous sinus because it's a big vein essentially that's sits around the artery. So you have to be able to open that vein. This is a little special foam that we use in the vein. It's used every day and throughout the brain and the spinal cord safely. And this foam eventually gets reabsorbed over time. but allows us to stop bleeding from veins very easily because it won't, unlike in an artery, it won't spread. So here you can see that's the carotid artery there that we're carefully dissecting this off of, and we start to see these little attachments, which were called ligaments, and then we can cut those ligaments and release this area of the cavernous wall. The cavernous wall is always there, and what we see here is the cavernous wall is actually full of tumor in this case. So it's very thick, it's very wide here because it's filled with tumor. So here we're cutting these various ligaments that have been described, again, in the article from University of Pittsburgh. And here we are just cutting away those ligaments and carefully dissecting around the tumor. By dissecting around it in this fashion, we can be sure that we don't leave anything behind. We're not pulling it out piecemeal, but we're taking it out in one chunk. And that can help us make sure we get a complete removal. Here are the final ligament attachments. So this is a tumor that has completely invaded this little wall that sits between the pituitary and the carotid artery. And so that wall has to be removed, and that's exactly what we're accomplishing here. So peeling that wall away. And there you can see that being peeled out. And with that comes the tumor essentially in one piece because it has completely invaded the wall. So there we can see it, a complete removal. And indeed, she underwent that postoperative crash that we look for. And we looked at when we do this, actually this medial cavernous wall is invaded in 85% of cases where the tumor even touches the wall, which is pretty incredible. If you look at it, it means really that removing this medial wall, if the tumor is touching it, this invasion is more common than we used to think, and removing that wall really is important. Now, there are some times like this tumor where there's no question that the entire cavernous sinus is invaded, and this is now where the tumor starts to go around the carotid artery and starts to go out to where the nerves are. And what we do is we essentially remove the tumor right up to those nerves, and unless it really has failed all other treatments, we don't try to dissect it off of the nerves directly because that can cause harm to those. And the way this shows up is that you can see here there's a certain grading system called the NOS grading system after an European pituitary surgeon who recognized that when the tumor on an MRI goes completely around the carotid artery, that it's involving the area of the cavernous sinus where those nerves are for eye movement. And so we tend to leave a little tumor in that case, not that we can't get to it, but philosophically it doesn't make sense. Remember, these are benign, slow-growing tumors, and things like a single shot of radiation can control a small area like this. There are other technologies that can also help us. This is something called indocyanine green. Indocyanine green is a dye that's been used for many, many years. It's commonly used in eye surgery, or sometimes when eye doctors want to look into your eye, they'll put some indocyanine green drops into it. And we use this, and it has now been approved by the FDA because of studies that we did here in Pittsburgh. And by looking at the cavernous sinus, what we do when we inject this dye and then we switch on a special filter, it actually can show us the difference in blood flow if certain structures have blood flow in them earlier, like the carotid artery, earlier than the tumor. And looking for these subtle differences when you wouldn't be able to tell where this artery is at all, using IC green can really help us resect tumors. And so technology like that's very useful. Now, moving on, really one of the biggest challenges when we look at invasive tumors is something called a giant tumor. And as you might imagine, a giant tumor is one that can really extend well beyond this area of the sella, which is the little saddle that the pituitary sits in. And the general definition, if you look at papers written by surgeons, is that anything over than 4 centimeters is considered giant. And to put that into perspective, 5 centimeters is 2 inches, which is about the size of maybe a large marble, like the shooter marbles, or a large red grape, something like that. But if you look at that and you expand it in all directions, that really gets to be quite large. And so really we're looking at an area of at least 2 inches around, something like that. But this is in an area that's supposed to be the size of a pea. So there simply isn't room for these tumors, and they're invading and growing into other areas. So here's an example of such a giant tumor treated at our center. And here you can see the size of it. And this man presented with double vision. He had some fatigue from loss of hormone function. And at the same time, while we were doing this, we also found small aneurysm on the same side as the tumor. And of course, this tumor had to be removed, but we needed to be comfortable dealing with those aneurysms as well. And our plan was just to look and make sure they weren't inside the sella. We have a lot of experience actually with clipping aneurysms through the nose, one of the first centers to do it, and arguably the most experience with that. Not that that's usually the recommended treatment, but in some cases it is the best treatment. And so here we felt comfortable removing the tumor. And one interesting thing, I'm going to pause here for a moment, is that a lot of times these invasive tumors invade into different parts of the base of the skull and the area around the pituitary, and they become almost like different sets of tumors. Like one tumor can have 2 or 3 different parts, almost like 2 or 3 different tumors. So here's the tumor, the part of the tumor that's actually invading and growing into the sinus and into the bone of the sinus itself that makes up the skull base. And so we can peel out that outer part, and now we have a more typical tumor that's extending up above the area of the sella. So we almost have to remove the first tumor first and then work on our exposure for the second tumor. Even though it's all one, it has just invaded between these different areas. You'll notice we're still using that same technique of exposing the carotid artery to be able to work safely there. So while this uses an endoscope and doesn't have any external incisions, there's a lot of work that's done on the inside. It's not designed to be the smallest opening. It's actually designed to have the widest exposure possible so we can do all of this removal safely. Now, you saw there before just drilling out the bone that's got microscopic tumor in it that helps prevent recurrence. And then here we're working in that area of the cavernous sinus, which is completely invaded. So there we can see there's that cavernous wall on the left side being dissected away. Here's the carotid artery. And then again, cutting out that medial cavernous wall, Dopplering that artery. And then here we can see the tumor up above, where it's extending up above the sella. So we look with 0 and even angled endoscopes to look up and make sure we get a complete removal of that area. And many of these tumors are quite soft until they start to grow into that cavernous sinus area. So we can use suctions, and that's just a little cotton tip that we're using to dissect through there. Works very nicely to kind of explore this area, which is the lining of the brain that separates the brain from the pituitary. And so now here we do use that fluorescence to look at the aneurysm. And sure enough, the aneurysm is hidden in this little area between the pituitary and between the brain. And that generally means that it's safe and doesn't need to be treated. It didn't rupture. We didn't expose it to the world by removing the tumor. And so it was safe to leave it untreated. So again, going back to what those advantages are and discussing them, we talked a bit about cavernous sinus, and now we'll talk a bit about supracellular. So we can have tumors that extend really quite a bit above the normal area of the pituitary. And here's a great example of that, where here you can see this tumor, the little sort of whitish thing in the center with multilobules, almost looks like Mickey Mouse or something. It's extending up into the brain and even up into the fluid sacs in the brain called the ventricles. And here is showing footage with an angled endoscope where this tumor can be just teased out of those fluid sacs. And so by teasing it out, we can much more safely remove it. We're not just reaching and blindly pulling it. We're carefully letting it roll out and dissecting it free from the walls of this fluid sac or ventricle. And there you can see it being teased out. And there, as it slowly starts to bring itself down, we can get a complete removal and get this beautiful view. So now that it's completely free, we can peel it out of there, and there you can see the tumor removed. And then looking up into those fluid sacs. And that's that final view, but previously it was felt that you needed to use an open surgery, a craniotomy to remove that, but we're able to get a complete removal of that tumor. So extension up into that fluid sac or third ventricle really was not a limitation. The cavernous sinus, we talked about that as an area that we can get to, again, by exposing the bone, this most feared area we can really freely access. And here we can see, again, as I mentioned, that cavernous sinus wall resection as a critical step. and we can have defined ways to get even more lateral out toward the cavernous sinus. And all of this has been well described and well published, largely by our group. And here's an example where we've done what's called a transpterygoid approach, which is just going through an area of the base of the skull to be able to get access a little more lateral into the cavernous sinus. And so here we see the carotid artery itself. There's a little branch off of it that was partly feeding the tumor and feeding the lining of the brain that doesn't have any impact on the function of the gland itself. And then as we start working outside the artery, this is the left artery, we're using this little stimulator, again, to stimulate the nerve. And as soon as we see the nerve, we touch it and stimulate it. And if we confirm that it's stimulating as we expect it to, then we know that that's as far as we should go and we should preserve that nerve. And this allows us to remove even a very invasive tumor like this. So as I'm going back to the concept of giant, again, we found that these giant tumors that extend into the medial cavernous sinus, that was not a limiting factor. So just because it's big, just because it goes in some of these bad areas, that does not mean that it can't be removed. It just means you have to have some of these more advanced techniques. So what are the limitations? Does this have any? Of course it does. Now, when there are some tumors that no matter what you do, there's going to be a little bit left. And what we found is that we're trying to take advantage of this idea of bringing the endoscope or the telescope into a certain area, but sometimes the tumor will sort of escape and send off almost a little satellite into space. And those we can't really get to so well because it's kind of hidden from our view or has escaped the corridor that we're using. We've gotten better at this over time, but that is one area where we can leave it behind. So, one of the take-home points of all that is that a lot of times people separate pituitary tumors from other tumors, and they really are not. This is a tumor in the base of the skull, as I mentioned. You can see here on the left, that's a picture of the base of the skull. It runs all the way from above the roof of the mouth and behind the nose, all the way back to the back of your head. And these giant adenomas, if you don't know what you're doing, can have a higher complication rate, and you can't treat them the same. The traditional techniques for pituitary surgery simply don't work as well for removing some of these giant and invasive tumors. We also learned over time that there are some ways that we can chase these tumors as we understand the anatomy better. There's something called the oculomotor triangle that we published on, where there's tumor that escapes into a certain region, and it almost looks like it's beyond where you can get to, but by understanding exactly how it got there and what its relationship is to critical nerves, we can actually safely access it. So here's a great example of the entire exposure of that area of the sella where the pituitary sits. It's sort of expanded because there's tumor in it. We've removed the bone, and then we can simply use 2 suctions to take out the tumor. And this is not really the part that's invasive. This is the part that sits in the middle. And then as we start going off to that right side, we're sort of working on the really invasive part. And just like that view of the portico, we can bring the endoscope into the field and have a perfect view of exactly where we're working and see things you could never see with a microscope sitting outside the field. And that allows us to chase tumor into areas like this oculomotor triangle. And we can see here this little ligament that runs around the carotid artery called the interclinoidal ligament, based on the 2 structures it runs between. And this little bubble just below it, that's where the tumor has escaped there. So here we're looking out with an angled endoscope. We're looking out at that little bubble where tumor had gone. And we're just going to follow it a little bit here. And now it's very important for us to understand and know this anatomy, because there's that ligament, but right in front of it or right below it and in the front of it is the 3rd cranial nerve, which is probably the most important because it controls all of your eye movement and even eye opening. So you can see here, this little bubble of tumor was coming just below those into this area called the oculomotor triangle. That 3rd nerve is actually the oculomotor nerve, or the eye movement nerve. And so here you can see just dissecting and stimulating, and that little bubble of tumor pooching through there has been completely removed. And even though this invaded that area around the oculomotor nerve, we can actually get a complete removal of it in this situation. Even very large tumors like this going through the oculomotor triangle, again, we can follow them, bring the endoscope in, and follow them all the way out to where here you're actually getting a glimpse of the brain, because we followed the tumor through that oculomotor triangle below the nerve that you can see up above there, and we can preserve the nerve and the arteries and still get a complete resection or even a near complete resection of a tumor like this. So other areas where we have advantage are the area called into the brain itself, and it's very rare for a pituitary tumor to actually escape into the brain. And now this may look maybe a little similar to the tumors that we saw before, but this is much bigger and much uglier. You'll notice it doesn't have a nice round surface. It's almost like a rough edge to it. It's got lots of little bubbles in it, and that's because it has escaped the membrane between the brain and the pituitary, and it's even wrapping itself around arteries. Those little black things running through there, those are arteries that the tumor has wrapped itself around. So this is a giant and very invasive tumor, and this is also in a patient who has acromegaly. Now, I'm probably not going to cure this tumor because it's so invasive. That means it's going to be growing in and stuck on things I can't safely remove. But we know with acromegaly, the more tumor I remove, the better we're able to control it with medications, and surgery remains the first treatment. So our goal here was to get the maximal removal of it. And here you can see during surgery, this is the area of the tumor where it's just grown down into the bone below the pituitary. So nothing, no fancy structures here I can show you, but just growth into the bone. And this is bone between the carotid arteries. You have to really know this anatomy to safely remove it. And here's even tumor that's growing up and out. So it's really growing out into the sinuses where it's very difficult to get good exposure of it. And this is the area right at the base of the skull where the tumor is extending up into the brain. And all this can be done safely through the nose, believe it or not, even though the tumor extends up into the brain. We have a lot of experience. We have the right tools and tricks for it. And there are many centers in the country that would never need to do a craniotomy for a tumor like this. So there's just taking some specimen and removing all of that part that was down low in the skull base. And then we really want to remove all the bone to expose the area of the tumor that's growing up into the brain itself. I'll skip through some of this in the interest of time, but here you can see we're doing the fluorescence. So taking advantage of all of our tricks and all of our tools to be able to see exactly where those carotid arteries are. You see them light up nice and early. And then we can see the artery even on the inside. We can see active bleeding that's going on. And again, using 2 suctions here, we can really access and remove all of these areas. We're using little scissors. We're using that little hook blade. That hook blade will help us get into that area of the cavernous sinus. And there you can see we're actually removing that, exposing that cavernous wall, and then finally opening up where the tumor is going into the brain. So here you can see tumor has actually escaped, and it's actually sitting in the brain substance itself. That's not brain we're cutting into. That's actually one of the other very thin linings called arachnoid, which is designed to be like or named after a spider's web. And the tumor's actually escaped inside this arachnoid. And so this is all tumor here, and the tumor is completely wrapped around arteries. So now we have to really become very careful with our technique to preserve the optic nerves that you're seeing coming into view there on the left, and to preserve the arteries running through this. And we know that when the tumor starts to invade like this, little teeny tiny arteries that can be important for the brain or important for vision can be at much higher risk, and so we really need to be careful with that. So here I am protecting some of those, that little cotton patty is that. But as I suction tumor here, I start to see one of the critical arteries that feeds the front of the brain. And look how this tumor is completely invading around it. You can tell unless I cut out that artery, I'm not going to cure this, but I can still take out 90% of the tumor. And that other small area can be treated with radiation or medication in the setting of acromegaly. So just because a tumor is invasive doesn't mean we can't treat it, doesn't mean we can't get to it, and doesn't mean we need a craniotomy. So here's the final view, and we can see on that top left, there's a tiny little bit of scarred in tumor, and that was actually treated with something called Gamma knife, and this patient's done very well with no tumor regrowth and great control of their acromegaly. We see invasive tumors. The more invasive they are, that we still can't cure them, and this partly just has to do with the tumor biology probably sticking to things, and there's something different about these invasive tumors. So prolactinomas, which can give you milk let down from the breast if you have what's called galactorrhea. And most of these are treated simply with medication that respond very well. But some percentage of prolactin secreting pituitary tumors actually don't respond to medication, or the people themselves are taking the medication can't tolerate it. That's also another reason that we have to remove these. And we're able to get remission in the vast majority of these where they can't take medication. And if not, we're able to keep them pretty close to it with other treatments. We found that the more invasive they were, the harder they were to cure, and probably no surprise there. So these really are the advantages of the endoscopic approach. They allow us to have access to areas we simply wouldn't have access to before. And these are all the areas that extend beyond and around the cell. It's very natural for these tumors to grow into these various areas. And we as surgeons need to learn how to safely remove them. And we teach courses on this to make sure that patients stay safe. Here's another example of a very invasive tumor. And if you look, that little black spot sitting in the tumor, really one on both sides, that's the carotid artery completely running through this. So this really isn't growing up into the brain, but this is really growing down into that sinus and into the base of the skull, where it's much more invasive. And so it's actually going out even on the other side of the eye. So one of our limitations is that these endoscopic approaches were designed to take out everything below the eyes and below the nerves and the artery, and when it extends out to the side, it still requires a small open approach. So here you can see tumor extending even into the bone all the way out here next to the temple. So it's really invading the bone by the temple itself. Not really, that at least area would require an open surgery. So here you can see the endoscopic endonasal surgery, again, another giant tumor, and I won't belabor this in the interest of time, but here you can see the tumor growing into the sinus. The nerves and everything we worry about are in the back. So again, like I said, it's kind of like two tumors. So we start by getting some specimen for the pathologist and peeling the tumor out of the sinus, which is the area that's a little lower risk, but still has to have a good exposure. We can then peel this. This is a little flap down towards the base of the nose that we raise that helps keep the blood supply. And then here's just the showing widening of the exposure. And then we can really start to expose this little loopy thing here, which is the carotid artery. And so using that little special hook blade to open this area and chase the tumor. The hook blade is nice because you can see it through the lining of the brain. You know you're not going to accidentally hook the artery or a nerve or something like that. And it allows us really safe movement here. Here we can see some bleeding coming from behind the carotid artery. But again, we're chasing this tumor, taking out all the tumor that's on the inside of the artery and the inside of the eye through this approach. And then we'll take an open surgery to be able to remove the part that's going outside the eye. And here's after everything. We see some scar tissue off to the side, but otherwise a complete removal of a very invasive tumor because we understand where these structures are and how to safely remove them. Of course, when we finish this and we take a large tumor out, you often have a hole between the brain and the nose, or where the base of the skull was, where the tumor was. And if you leave that hole, in many cases, it will leave spinal fluid in contact with the nose, which could, of course, lead to a disastrous infection and meningitis. So there's been something called the nasal septal flap, which again was partly developed, or at least initially utilized. It was actually developed and come up with by a group of a couple of surgeons in Argentina named Haddad and Basagastegui, but we really popularized this flap. And here you can see this living flap. It's attached to its blood supply in the nose that comes from the septum, doesn't affect the septum function, and allows us to cover up this hole. It can cover even very large holes in the nose. And here you see it in the office, healed beautifully, looking like the rest of the normal mucosa. And this drops our CSF leak rate, even for some of these giant tumors, well below 5%, and really more around 2 to 3%, which is really the standard. So this nasal septal, which is a flap, which is living tissue, really has been important to reduce spinal fluid leak for any large skull-based tumor, but especially these invasive pituitary tumors where you have to protect the carotid artery and you want to separate the brain from the nose. So in conclusion, I think endoscopic endonasal pituitary surgery has rapidly becoming the standard of care. I believe it was about in 2015 where for the first time there were the same or more endoscopic endonasal pituitary surgeries being done. And then since then, it's only increased so that the microscope is falling out of favor. The endoscopic approach is something that's been at our institution for more than 20 years. And we really think the advantages, well, the interesting thing about it becoming the standard is that there's not been one big study that showed, oh, hey, here's outcomes from doing this with an endoscope, and here it are from doing it with a microscope. It just is so obvious to surgeons that you can see better and you can access more, and being able to do that allows us to do surgery in the same way as if we had a whole big open approach to this. We have the same safety, we have the same view, and we have the same access to these critical structures that, just by using an endoscope. And remember that this becomes most critical for invasive or giant tumors, because these are not just a simple little pituitary tumor, but these are truly skull-based tumors that can involve regions of the base of the skull, including arteries and nerves. And so our understanding of all that anatomy and our ability to deal with these big tumors is really critical and is a big part of experience as well. These invasive tumors are tumors, again, that extend into or around the cavernous sinus and the carotid artery. They extend in what's called the suprasellar space, or above the sella or the saddle or the pocket where the pituitary normally sits, and into this subarachnoid space, which is around the brain. And then finally, the clivus, which is really the bone at the base of the skull. And we can treat all of these with low complication rates. Here's just a wonderful artist's rendering of the pituitary. And I think this we had this commission because it really, I think, commemorates our passion for the pituitary. It's this most incredible gland that's got this intricate blood supply and association with critical important structures, but also is the critical flow of hormones for our entire bodies that really makes a difference for all of our health and well-being. Again, thank you very much for allowing me to be a part of this PNA webinar and a part of this wonderful society. Thank you very much.
Thank you so much, Dr. Gardner. That was an amazing presentation. We do have
Thank you.
Quite a few questions here. So
Sure.
I'll go ahead and start with the first one. It is, what role does a high Ki-67 index play in invasiveness of the tumor?
That's an excellent question. A very, very, very sharp question. So Ki-67, it's just a marker of how many cells within a tumor are active or actually growing. Basically how that's calculated, it sounds very precise and very fancy, but a pathologist, and pathologists are experts at this, so they do it well, but they look at the tumor, different parts of the tumor, under a microscope, and they look at, there's a special stain that can show them when a cell is in what's called mitosis, which is where the cell is actively turning over and actively reproducing another cell. And they count the number or the percentage of those that actually is doing that, and that's where they get that number. So as you can imagine, if your tumor has more cells in it that are active and reproducing, that tumor grows faster. As it grows faster, it invades more. It has nowhere else to go. And so we find that invasive tumors have a higher Ki-67, and higher really is a subjective definition. Probably anything above 10–15% is higher for a pituitary tumor, but these aren't cancers. That's the good news. So they can be invasive, they can have a little more activity, which you see in the Ki-67, but they're still treatable. It just tells us that this is a tumor that we need to make sure that we get rid of, or if not, do other treatments like medication or perhaps radiation to control these tumors.
Okay, great, thank you. The next question is, if somebody has a high index, 10%, but gross total resection of a functioning tumor, do you recommend radiation after a surgery?
The short answer is no. If it's truly a complete removal, that is the best treatment. Now, it's wise to watch and make sure that there aren't areas of regrowth. So we might watch a tumor like that more often. So whereas, as opposed to getting a scan every year or two, if there's a high Ki-67, you would watch it more often. More importantly, if the specific question is about functioning tumors, and what we mean by that is a functioning tumor is any tumor that makes hormone. The majority of pituitary tumors, many of them, don't function. Prolactinoma is the most common functioning tumor. It can have a very high Ki-67, but actually is controlled beautifully most of the time with medication. That high Ki-67 with a complete removal in a functioning tumor, we would still monitor the hormone levels, and maybe then if the hormone levels started to creep up, that would tell us that radiation is necessary. But in my opinion, if there's no obvious tumor left on an MRI, if there's no evidence of extra hormone on testing, then there's no evidence of active tumor, no matter what the Ki-67 was.
Okay, thank you. Next up, we have, what if a tumor is particularly firm in the cavernous sinus and can't be removed whole and must be gradually scraped away?
Great question. And so the interesting thing is that most pituitary tumors are soft. And so as you saw in the videos, I can usually suction them. Somewhere around 10% of them in general are fibrous, but for some reason, even the soft tumors, when they invade into that cavernous sinus, that part of the tumor becomes more firm or fibrous. There are theories about that, and there's a lot of study that a lot of us are doing to try to understand why is one part of the tumor different than the other. Now, there's something that's somewhat obvious, is that if this tumor can invade into that area, there's something different about it, because not all tumors invade there. But also when it actually, the cavernous sinus is this little network inside of these veins, this big vein which sort of has a network inside it. And that network itself is fibrous. So as the tumor grows into it, it can become more fibrous because it's intermixing with scar and other fibrous cells. But the truth is there's probably something genetically different about that part of the tumor that also makes it more fibrous. So the answer to that is, this is why when a tumor becomes fibrous in that area, it's so important to have expertise with working around the carotid artery, because the truth is the greatest fear is damage to the carotid artery itself. So we have to understand that anatomy. We have to have experience with it, and that's our entire team has to have experience with it. And we have to be able to do the same dissection as if I had it all exposed, let's say the face or the head opened up and I could work on that artery, but through the nostrils, we can do all of the same things. So we can carefully cut it away from there. We can suction it. We can dissect it. We have developed all of the tools necessary. We can burn it with a bipolar if we need to. We've developed all the tools necessary. The truth is that there are some times that it's not the surgical technique that matters. No matter what you do, if the tumor has actually grown into the wall of the artery or around and into the lining of the nerve, then it's not physically possible to remove it without damaging that, but you can remove right up to that point. So I hope that answers the question. The short answer is you have to do it very carefully with excellent standard microsurgical technique, but through an endoscopic approach. So you really have to have the technique and the experience to deal with those tumors.
Okay, thank you. Next up, have you seen prolactinomas also being invasive into the bone below the sella?
Yeah, and in fact, a lot of times if I see a tumor first diagnosis and the tumor is invading down, and it kind of looks what I might call ugly, in that it's not this nice round ball that's sort of respecting. Many pituitary tumors are very respectful. Invasive tumors are not respectful. They're not respectful of where they began. It's like if I have a house or an apartment that I sit in and I get so big and I spread my stuff everywhere that it starts spilling out and out on the porch and out in my neighbor's yard and everything, it's not a very respectful way to live. Well, some of these tumors are like that. They don't stay in their space. And that's when we say that they're invasive. And so prolactinomas are notorious for that. So when we see an initial very invasive tumor, that always says to me, maybe this is a prolactinoma. In fact, I hope it is, because if a tumor is very invasive, surgery is more difficult to cure it. I can take out 90–95% of it, but if it's really in some of those areas, it can be more challenging. A prolactinoma, though, I can either treat it with medication alone and never have to operate on it. And no matter how ugly and invasive a prolactinoma is, as long as it responds to medication, which most of them do, then it will be very easy to actually control. If it doesn't respond, then we have to be able to remove all those areas it invades, including the clivus, which actually is just bone. So as long as we understand that anatomy, we can safely remove that bone. So the short answer is yes, it is common. It can be common for prolactinomas to do that, but either by removing it, either if they don't respond to medication, if you remove most of it, they can then become more responsive, and they really are almost always completely manageable.
Okay, thank you. Next up, we have, is there any value in a PET scan of the brain for MRI negative tumors?
So at this point, there's probably not. There are some techniques, something called dotatate, for example, which can look at specifically neuroendocrine tumors, and the pituitary is a neuroendocrine tumor. It's a fancy sounding term, but adenoma is actually now being replaced by the term PITNET, so which is a pituitary neuroendocrine tumor, because the pituitary tumor is an endocrine gland. It's a hormone producing gland. But the problem with PET scans in the brain is that a PET scan in general is looking for metabolism or activity that is abnormal. And throughout most of your body, there's a kind of a quiet lower metabolic rate, but can you guess which organ in your body has the highest metabolic rate? It's your brain. So because the brain has such a high metabolic rate, most PET scans just show this big bright light that's the brain, and you can't pick up anything in it because it sort of washes everything out. Now, there are some specific techniques that are being looked at, like dotatate, to try to find teeny tiny tumors, but even that is a challenge, again, because of the bright light of the metabolism of the brain. So the short answer is, in general, no. Very rare situations where you might try that just to see if you really can't find it.
Okay, great, thank you. Next is, what question should I ask my neurosurgeon 1 year after surgery for a partial resection of a tumor? The supracella part was removed since it had pressed against my optic chiasm. I still have 2.2 centimeters by 2.1 centimeters by 12 millimeters remaining.
Well, I mean, I think there are a lot of factors in a situation like that, and no two tumors are alike. No two people are alike. And for example, if you have a 2 centimeter tumor in someone who's 20 years old, that's very different than a 2 centimeter tumor in a 70 or 75-year-old. These tumors actually, over time, most of the time, become less aggressive. They lose the ability to grow kind of like we do. They slow down a bit. And so a 2 centimeter tumor in someone who's older, I would be less worried about. But the question that you should really ask your surgeon is, what do you think is going to happen, or what is happening with this part that's left? Do we need to do something about it? And if so, what can be done about it? What are the options for it? And there's a whole wide range of options for it. Generally, for a larger tumor like that, and we try to avoid radiation, because the bigger a tumor is when you radiate it, the more radiation you have to get, which means more risk of damage to structures, and the less likely the radiation is to control the thing. So bigger tumors, generally, you want to at least have as much removed as possible, so the smallest area possible can be radiated to make it more effective. So I think that's an important question, is, what other things can we do? What can be done to avoid higher doses of radiation? And does anything else need to be done at this point? Those are really the important questions. One question to always ask any surgeon, if you're considering surgery for pituitary tumors especially, is how much experience do you have with this? There's pretty good evidence that shows that you need to do at least probably 30 to 50 of these types of tumors, either in this area or around it, per year, and it's your entire hospital, the surgeons, the radiologists, it's everybody involved with it. It's like anything, the more you do of it, the better you are. And so a good question to ask any surgeon is experience.
Okay, thank you. What are the newest areas of research with most promise for invasive recurrent pituitary adenoma treatment?
There are a few of them. There are things as basic as areas of research of anatomy and surgical technique. A lot of the things that I showed you came out of research done in an anatomy lab to understand those areas where the tumor is invading. And that's true research. You might think of it as, well, you know, all of this is known, but believe it or not, much of the anatomy through the nose was not described prior to the endoscopic endonasal approach. And so there's anatomy research, which is really allowing us to get better removals of these tumors. But on a much more basic science level, there is an explosion of understanding of the genetics of these tumors, what we call molecular drivers. And sounds real fancy, but it basically means either genes that drive it, like why did it flip a switch? Why did it start invading? Why did it become more difficult? Why did it start growing faster? One of the most common questions, understandably, patients will ask me is, you know, what caused this? And the truth is, we don't know. But there's a lot of research studying these tumors. There are a couple drivers, one called TPIT and PIT1, that are genetic, that are genes that we know can define certain kinds of tumors. They can define invasiveness. And as we understand the genes that drive it, we can start to understand maybe how do we turn those genes off, or how do we block the effect of those genes to try to stop the tumor. There's also research being done with medications. There are sometimes cancer medications or even immune medications that might be able to help your body fight some of these tumors. There's good research being done there. And of course, there's research in newer radiation techniques to try to limit the damage and improve the effectiveness. So I think probably the most promising, and look, the hope is that, you know, we make surgery less and less necessary. By understanding the genetics of these tumors, we will understand better, you know, does that 2-centimeter residual tumor need some other treatment now because its genetics tell me that it's probably going to grow back and be more invasive, or does it not tell me that? So we can understand the tumors better and hopefully treat them better. I hope that answers the question, but it's actually an area that's exploding and shows a lot of promise.
Okay, thank you. We do have time for a couple more, and then anybody whose question has not been answered, I will save and send over to Dr. Gardner and get answers for you that way. Next up is, it seems that we have come a long way on the surgery. Do we know what causes these tumors yet?
Yeah, great question. That kind of fantastic question. Kind of alludes to what I was just talking about. And look, I would want to know, if I have this tumor growing, what caused it. We don't think that, you know, first of all, that there's something that people are doing that's causing it. We don't know of some bad diet that causes it. Smoking can cause lung cancer, but we don't think it causes pituitary tumors. So there aren't, you know, cell phones, things like that. These are just very common. And if you think about it, your glands are some of the most active parts of your body. There's no time, day or night, they're not doing something, and your pituitary controls every other gland. So it's constantly taking feedback from your glands and giving feedback back and forth to them. It's constantly regulating that, and that requires a lot of activity. The more activity any part of your body has, the more turnover it has. Each time it turns over and is active, it has a chance to make a genetic mistake. Those genetic mistakes make cells that don't grow under the usual control, and that's called a tumor. You know, a good example is someone who has colon polyps, or maybe their diet is not high in fiber, and that makes the colon be more active, and since it's turning over more, it can make more mistakes, and that can lead to colon cancer. This is not a cancer, but the same idea comes true. But we don't really understand the genetics or the real deep dive into understanding of exactly what causes these, but we know on a very surface level why they would occur there, and we're starting to understand the genes that drive this, and hopefully over the next decade that will mean we understand better how to treat them or stop them.
Okay, thank you. And then our final question for tonight will be, how much more challenging is it to resect a tumor that has been previously irradiated?
Irradiated?
Thank you.
Yeah, it depends on the size and the dose and a lot of those kinds of things. And there are many times if a tumor has been previously irradiated, it's not more difficult at all. But if it's been given high dose radiation more than once, it's the there are two factors there. One is that a tumor that needs radiation is probably something a little different about it many times, and so maybe that tumor itself would be more difficult whether you radiate or not. But the second thing is that radiation can have effect on those structures around it to make them a little more delicate, including the carotid artery and nerves. So it's a very hard question to answer. I would say it doesn't make it not treatable at all. It doesn't make it so surgery is not an option. It makes it, my short answer would be a little bit more, but sometimes no different at all. So I wouldn't say that just because you've had radiation, you need to be scared that surgery is going to be 10 times more dangerous. It's not the case at all. In fact, it's not even twice as dangerous. It's not measurably more. We just know that some situations we have to be a little more careful.
Okay, thank you so much. That was a really great and valuable presentation, Dr. Gardner. We really appreciate you coming out and helping us all learn.
My pleasure. Again, anytime I can help, please let me know.
Thank you. This concludes today's webinar presentation. We appreciate you all taking the time to join us. If you've missed any part of this webinar, please feel free to visit us at our website at www.pituitary.org, where it will be posted. After the webinar, there will be a brief survey. Please fill it out to help us provide you with information you need. Thank you for joining us and enjoy the rest of your day.